for outpatient transformation at Harrogate and District NHS Foundation Trust. And we have Phil Hammond, who's consultant rheumatologist at North Bristol NHS Trust. So the plan for today is that each speaker is going to give a brief presentation and then take questions from the audience. In terms of the questions, if people could please use the chat function or the hand function, and I will do my best to keep an eye on both. We probably need to keep questions and comments quite brief as we've only got 45 minutes. So I do apologise in advance if I need to cut short any discussions or if I miss out any questions because we need to move on to the next speaker. So I think that's it from me, and I can hand over to Gwai to start his talk on remote monitoring using a digital app.
Thank you very much, Emma, and welcome everyone. Thanks for joining, and thank you for asking me to present today. So my brief presentation today will be about remote monitoring using digital app and our experience from Harrogate Rheumatology. So I'll give you a brief background about Harrogate and District Foundation Trust and the Rheumatology Department, and then I'll have a chat about the app and why we decided to use the app and what we were hoping to get from the app and are still hoping for, the process and implementation of using the app, the story so far, barriers that we've come across and how we've overcome them, and the next steps. And so Harrogate and District NHS Foundation Trust is it's a district hospital which has 5 consultants and 4 clinical nurse specialists. We have a drug budget of £1.5 million, and we have just under 3,000 patients who are on disease-modifying drugs, which are drugs which require regular monitoring and reviewing. And the theme of this talk is throughout this is based on these 2 images here. The one on the left is a lift and a lift boy, and I don't know how many know, but whenever everyone's been in a lift before, and whenever you go in a lift, you normally press a button to go up or go down and to open a door. And that technology existed for several years whilst lift boys were still in employment. The reason being that people didn't quite trust the use of the lift, so they had employed a lift boy to press those buttons for them. And that was in the past. And coming to the present, in Tesla, there's a lot of technology now for automated driving. We're not quite there yet, and so the theme is that the technology exists, but what are the barriers and why are we not using it? So with this idea started with my consultant colleague, Dr. Green, who a few years ago felt that we should be using an app, and there was a lot of thoughts that would make it quite useful and beneficial. Firstly, there's a patient safety point of view, where improved data availability and accuracy on patient outcomes would help guide management on their patient journey. And patients would be able to be monitored more frequently, which would allow us to detect inflammatory arthritis of patients who are not improving or worsening. We also felt that it would help the patient experience. It would improve patient education and allow patients to be more involved and empower them to help manage their conditions. And it would reduce unnecessary time and travel for patients to see clinicians. It also helped with efficiency. So there'd be a reduction in requirement of physical use in outpatients. It'd be a better use of staff time by reducing unnecessary patient contact. It'll help direct cost savings for patients in terms of time and travel, and it would reduce non-attendance in outpatient clinics. And we estimated that it would save over the course of a year £30,000 and hopefully almost £200,000 over 5 years. So to start off with the process, we needed to identify and approve the app from an internal governance point of view. We needed to get over the barriers of registering patients onto the app, and we needed to demonstrate the effectiveness of the app using and its how we can make real changes. And I'll talk about each individual one of these. So the first step is we need to decide which app to use. And as I'm sure a lot of the audience are aware, there's a plethora of apps out there. And what we needed, and from experience, was an app which could calculate for us. So in rheumatology, we we have different scoring systems which we can use, which I'll go on about a bit later on. But adding all the scores up to give us a overall calculated score is important. And it sounds like an obvious thing, but there are government approval, MHRA approvals that are needed for this, because calculation for an app crosses the barrier from crosses the barrier into a device which needs MHRA approval. We also needed something that was responsive. So we wanted something where if we needed a change, or we asked for something to be altered slightly, that we could get in touch with someone and they could try and change it within a few weeks or quite quickly, rather than wait a year or a few months. After that, after choosing an app, we needed to go through the internal governance approval, and Dr. Green went through that, and it wasn't difficult. It was time onerous, but there was a lot of barriers involved in that, and of course there's the funding requirements involved, where we need technology, who's going to fund for the app and the use of the app, and we also needed staff to be involved in that as well, so recruiting the patients. And we had a variety of different ways: Band 3 assistants, registrar, medical students, lots of people who were keen to be involved. And this is the app which we use, the Living With app. On the left-hand column is the sequence in which, from left to right, is the sequence in which you can use the app. So you open the app up on the left, the first left picture, and then I've circled here My Health, so you click on that, and then you click on Questionnaire, and then you click on Rapid 3 Start, and then you fill in the form. So there's 15 questions, and it goes on to the next one. And so it was very straightforward. Patients haven't complained of any problems with it, or many problems with it, and it takes a couple of minutes. Okay, the next step was recruitment. And recruitment is probably the most difficult part of this, we found really. And we enrolled patients in clinics. So whenever we saw them, we said, do you want to take part in the app? And then we enroll them, and it takes about a minute or two to enroll them. But that's probably a bit too long in the actual busy clinical environment. We're enrolling them in biologics clinic, which is an obvious area where patients are taking disease-modifying drugs. And so we contact them before they're due to come into biologics clinic. And when patients were being sent COVID letters about their vaccination status, we added on an extra letter in the same postal envelope saying, would you be interested in taking part in this app? So the story so far is that, let's see if I can get a pointer here, laser pointer. Hopefully you can see the laser pointer. Please tell me if you can't. So we started a couple of years ago in June, and we weren't making much progress. And then we started asking medical students and the registrars, and we got an assistant to help us out. And around this time, towards the end of last year, we started taking off here. So we needed a lot of support, but also getting it aware in this clinical space was quite very important. And there's a bit of a dip here, probably because it's summertime where everyone's on holiday, so we don't really get many people. But we're still continuing to recruit, and we're nearly at 400 now. And just some data that we've got here. We've still got to dig into this data. It's quite interesting. We've got 380 patients, predominantly female. Like I said, I don't know why we've got this data, but it's an interesting undertaking. It'd be an interesting task to undertake and delve deeper into it. This is the demographic of the age here, and most of them are between the ages of 50 to 59. Sorry, the colour doesn't come out here, but it's 50 to 59. We have actually got one person over the age of 90, which surprised me a bit, but most of them are between 50 to 70. One of the things we have to consider as well is retention, and we're still working on understanding this. We know we've invited 450 people, and 85% have registered, but only 173, so about 50% have completed it in the last 60 days. Maybe that's because they haven't seen us in 60 days and they forget, so maybe we can send out a message. Maybe it's because they're feeling well, so they don't feel that they need to engage so much, but it's something we need to dig down a bit deeper and understand. And we're right in the middle of the process of rolling out this pilot now. There's been a few delays. We were hoping to do it at the beginning of this year, but we've done it now. The reason there have been delays is because of COVID and staff illnesses. But we're starting to get there. And I'll show you two graphs. So this is the outcome measure. This is quite easy to find. You click on the patient's details on the website, Living with the website, and you click on the patient and you click on the rapid 3 score here. And this is what we've got here. This patient's obviously, green is good, orange is, amber is okay, not so good, and red is not well. And the patient is obviously not doing well at this point. And at this point, we give them a steroid injection and start them on a disease-modifying agent. And you can see that they do quite well here. And then maybe the steroids start wearing off, and maybe the DMARD starts kicking on about here. So it gives us an understanding of how the patient's doing. And it's also good for the patient because they know how they're doing. And this is another graph, which shows the patient doing really, really well. And we can utilize this data. Do we need to see this patient if they're doing really, really well? Can we defer their treatment? Do they need to be seen face-to-face? If they need to be seen, can it be telephone? And these are things we're still trying to understand and trying to roll out by auditing by doing a pilot and auditing our data. So it's a good idea. It's starting to work. We're getting there. We've started to reach a critical mass of 400. We're hoping to recruit about 1,000 people in total at least. So we're getting there, but there have been barriers, lots of different types, and things that I've highlighted here include infrastructure barriers. So staff, for example, it's having enough staff to help recruit the patients, explain what this app's all about, explaining how, if there's any problems, who do the patients get in touch with. Funding barriers as well, which I've alluded to earlier on about paying for the license fee of the app, and also maybe staff members to help out. Patient retention, we've mentioned, but also digital inequality. We don't want to roll this out to everyone and some people not be able to use it. So we've got to try and understand how it can affect them, especially with age. Clinical barriers include colleague engagement. For example, some colleagues may not be able to see the value in this, or may find it that it prolongs their clinic, which is completely understandable. And our aim is to try and minimize or improve clinic time, really. But that with change sometimes comes difficulties. And it's about trying to demonstrate that the change should be positive if we can demonstrate that, and if indeed it is positive. Pathway changes take time. I'm sure everyone who's a clinician or involved in clinical care appreciates that there are barriers along the way to changing pathways and different types of barriers. And finally, the technology we've encountered as well. So we've been working quite close, talking about being responsive. We've been working quite closely with Chris, who's the chief exec, and his technological crew in trying to establish DAS 28, because we use Rapid, but we do appreciate that DAS 28 is more clinically useful, especially since NICE use it as a clinical currency in which we can decide on DMARDs and disease-modifying agents. It's not as simple as it sounds, because what we need is CRP incorporated into the actual scores, and that involves sharing information between systems. But Chris is working on that at the moment. And there used to be two-way messaging as well, and that meant that we got a few messages once in a while saying they weren't feeling very well, and that wasn't what this app was designed to set up. And we've asked Chris, who's responded by saying we'll turn off two-way messaging, so we can do one-way messaging. But if they need to get in touch with us with flares, for example, they can contact our helpline. Okay, so our next step is to understand the use of the app, why people use it, why people don't use it, why people aren't continuing to use it, audit its use in clinical practice. You'll be hearing a talk from Phil down in Bristol, and we're collaborating and hopefully working together on quite a few ideas. So hopefully across trust it will be more powerful, and we're hoping to hit a target of 500 by December 22 and 1,000 by next year. And thanks to people, first of all and foremost, Mike Green, who's picture is this there. He's the consultant who's driven this and made the changes, so it wouldn't be anywhere near where it is without Mike, the rheumatology department living with, and our funders, Friends of Harrogate, Amgen and Janssen.
Excellent. Thanks,
Thank you very
Guy.
much.
Brilliant. Now, I can't see any questions in the chat function. Does anyone want to ask any questions? I want to give people an opportunity before we move on. No.
There's a couple of, have you seen the messages?
There's a message about sharing the slides. I'm sure that's up to you too. I imagine that's fine, is it?
Yeah, and someone mentioned about self-drive taxis.
So, yeah. Excellent.
Yeah, that's in San Francisco, not the UK. I did read about that actually, but it's not quite autonomous. I think someone has to sit there as well. So it's an interesting thing. It'll come about, but when will it come about is the next question.
Guy, the research room has a question. What are you doing to capture cost savings, or are you trying to capture them? Because I can imagine it's an important point for a service provider.
Yeah, so that is a really important point. I'm sure Phil will touch on this because he's a bit further down the line than we are, and he's actually calculated cost savings. So I'll answer that after Phil, if that's okay, because we're doing something similar to what he's doing, and he might mention it. Sorry to hand that one over, Phil.
We have a couple of questions. I'm not sure who was first. Brona? You might have to unmute. And if you could just ask your question.
Sorry, that was accidental. Forget that.
Oh, okay. I'll move to Brian then.
Hi folks, how are you doing? Apologies, I joined slightly late, so you may have covered this, but in terms of adherence, how do you find patients adhering, let's say, more medium term, longer term to using the app? Again, apologies if this was covered already. If it is, I can certainly leave this to offline.
I'm really sorry, Brian. My speaker's really quiet and I can't seem to increase it anymore. I don't know if Emma, you could repeat the question for me because it's clearer from you.
The question is about adherence and how to keep people engaged over time.
So that's a really good question, actually. We're still trying to understand why people aren't adhering. So we were talking to Phil last week about retention, and 50% is probably about right, if not less. He's finding as well. He probably might mention that later on. How we can try and increase adherence is firstly showing to the patient the value of the app. So if we speak to them or see them and they come into clinic, we can say, I can see that from the app, and show them the app. We find that patients really find the value of that. The other thing as well is that we've turned off two-way messaging, which I've mentioned already, but one-way messaging we've kept on, and that gives us the opportunity to message them if we need to. We haven't done this yet, but if we need to say, oh, we've noticed that you haven't filled in the app recently, are you happy to do this? Time burden on the patient is something that we are mindful of. So what we try to do is ask them to do it once a month. That's our view. Why we've chosen once a month isn't necessarily evidence-based, but once a month or once every couple of weeks is fine, and it gives us a good trend.
Thanks, Guy. I have one more question, if it could be quite quick, and then we can go on to Phil's talk. It's from Shabina in Airedale, and she was asking whether the app was in existence or whether you developed it, and how much the license fee is.
Thanks, Shabina. Hi, how are you doing? No, it was already in existence. So we went round and had a look at different, Mike Green went around and had a look at all the different types of apps, and as you know, there's quite a lot out there, and it's about choosing the right type of app for the right. It's about choosing the right type of app for what you need, and the app we chose was what was best for us, we felt, and it's worked quite well. And how much is the license fee? I can't remember off the top of my head, if I'm being honest. What we did ask for was we asked for funding from the Friends of Harrogate charity to help provide us for some funding for it. But I can get back to you, Shabina, about how much the license fee is when I dig it out, but I can't remember off the top of my head. I'm sorry.
Okay, great. Thank you. Sorry to rush everyone along. I'm going to hand over to Phil.
Hello, can you hear me?
Yep, very well.
Yeah, great. Okay, so we're just loading up the presentation. So thank you very much, Gwai. I'm happy to outline a few of our experiences. Let me just should be loading up now. In terms of adherence, just I guess to go on that, we've had a look at our data, and after about 1 year, have about 70 to 75% of patients who have downloaded the app are still using it. And then if we go out to about 2 years, it drops to about sort of 55, 60%, and then you get a sort of a bit of a sloping off of the curve over time. So Emma, can I just check? Can you see my first slide?
I can, yeah.
So it's my conflict of interest. And I will move on. So as Emma said, I'm a consultant rheumatologist at North Bristol Trust. I'm briefly going to talk a little bit about sort of ingredients for change, something about tools, a bit about how we've implemented it in a sort of more, both in a sort of ad hoc, but also more formal way in our biologics service, and a little bit of looking at cost efficiency and patient feedback. So I think first thing, and I mean, it might be very obvious, but I think worth highlighting that when you want to make a change, you've got to have a few key ingredients. You've got to have the need for change. You've got to have the engagement, and also you've got to have the tools to enable that change. And I think it's important to say that the app in and of itself is not the change. The app is a tool to facilitate a change in a way of doing things. So, you know, it's not a matter of going, oh, we now use an app and that's our service. It's actually the app can facilitate new ways of doing things. And there are obviously other things in terms of need and engagement to get things moving along. We know that outpatients need to change, and they have changed radically over COVID times, but it is a problem that needs a solution. The traditional model of just calling people in, seeing them even when they're well, is not necessarily always the most optimal uses of resources. I think it's important to say that, you know, reviews of people when they are well is not totally a wasted thing always, because it's important to maintain that relationship with patients, and sometimes they do have other things they want to talk about that's important to their care overall. But we historically haven't had a particularly targeted way of seeing patients, and there's an increasing burden on our services. As recognised by multiple reports and the long-term plan, which is now back many years ago, and the 2018 RCP reports. But NHSX, or now NHS Digital, has been keen to drive forward remote monitoring. So I think the really important thing that things like remote EPROMs and using particularly like using an app to ask patients to record how they're doing remotely, is we can move from this scenario on the left-hand side of an unclassified disease activity of our patients when they're in the community. We don't know how they're doing, and then we sort of based on how we saw them some time ago, we call them in for their appointments, or maybe they tell us that they need to be seen. And it'd be much better if we could move much more towards having an idea about how our patients are in the community. You know, those who are maybe struggling, those who are doing well, so that we can really target the resource that we have at the right people at the right time. And from a patient perspective as well, they don't really like coming in when they don't need to. So I like this quote here: "I dread outpatient visits and resent the time and expense when an email exchange or a phone call would have sufficed." And all of us will have had experiences of patients who sort of are slightly miffed because you're running a little bit behind time. They come in, they sit down, and you say, "Oh, you seem fine. I'll see you in a year." And they go, "Well, you know, was that it?" And then on the flip side, you have some patients knowing that they only have a set amount of time, and how are they going to tell their consultant how they've been in the last year or 18 months in that time? So really, in terms of our timeline for adoption, as Gwai said, we've been using it for a few years. I've been working with Living With since 2015, and we had our clinical pilot launch in 2018. And we, as the sort of graph here looks very similar to Gwai's, we're sort of gradual sort of accumulating patients, and then this mystery event happening in March of 2020, which changed everyone's sort of ideas about what could be done remotely. We now have nearly 1,000 patients, 994 this morning, and we've recorded over 34,000 patient-reported outcome measures via the app. So really, we want to try and improve our clinical triage. We want to see the right person at the right time, ideally. And these are some of the graphs that you've seen with Guide, the sort of what we can see when we see patients' outcome scores, and some of the screens as well. So before we did this, we wanted to sort of just find out, so this is going back to I think it's 2018 and 2019, do our patients have the technology to use this sort of thing? So we've got a group of patients in the outpatient while they were waiting for their appointments, and majority female, as you'd expect from a rheumatology population, a broad age range of 17 to 86, and 87% of people had a smartphone or a tablet and an email, which is what we needed for people to be able to use the service. So the vast majority of our patients had the technology required to be able to access this service. And we also identified the biologics service actually as a target clinical pathway to look at that we could implement this in, because as many people will know, we have a requirement to review patients every 6 months while they're on biologics. Biologics are excellent treatments, and most of the patients who actually are on these biologics medications are actually doing doing really well, and yet we were calling them in every 6 months to sort of sit them down and go, yep, you're fine, as you say you are, and not much was changed. So we looked at a handful of our patients randomly, and identified actually in only 20% of the appointments was any change at all made to the patient's treatment. So a large number of appointments there that potentially you could do remotely, or maybe what we call virtually, so asynchronously. So with that, we moved from our old pathway, which was a very sort of linear sort of approach to things, face to face, with a nurse practitioner, and then clinic reviews as per NICE, and then 3 monthly, 9 monthly, and then alternating between the medic and a nurse practitioner. And we adapted that. We worked with the team, and this was very much led by our consultant pharmacist, Emily Rose Parfitt, and worked with her team of nurse practitioners and allied health professionals to build this. And this was at the beginning of COVID, and so with the idea being that initial appointments ought to be still face to face. This is when thinking in the future when we could see people face to face, but when we have our baseline assessment, that ought to be face to face. But then actually a sort of a review at a couple of months just to check that people are engaging with the treatment, and then their NICE assessment at 3, 4 or 6 months. And this ideally should be face to face as well. But then after that, going on to this cycle of virtual reviews here. So they see a medic, and that could be maybe a video review, and then they would go on to see a nurse practitioner after 6 months. And this could be either video or telephone, or what we call virtual. And that's if they were filling in their app scores and they were reporting being, say, in remission or low disease activity, and their bloods were fine. We actually took that as this is a review. We don't actually need to call you. We don't need to have a video call with you. Everything's fine, and then move that on to another 6 months. So improving efficiency there. Of note, the patient did get, prior to their planned appointment, they did get a call from an administrator just checking that they were happy to have this virtual review, because we were aware from having gone to our patient groups that sometimes people save up questions for these appointments. So we didn't just automatically defer it. We checked with them that was okay, and then would refer that on. So we went through this cycle, and then every 3 years as a safety net, as a face-to-face regardless. But at any point in the cycle, people can be escalated anywhere from virtual all the way through telephone, video to face-to-face at any point by patient or by the clinical team. We've got this move to this hybrid clinic model where we've got this virtual. So as I said, that's where we check their app scores, we check their blood tests, and if we're happy with those, then we administer their next prescription for another 6 months, and the patient gets a pro forma letter that just says everything's fine, carry on, basically. For if we're not sure about the scores maybe that they've been filling, or maybe they haven't filled any scores in recently, or maybe they're not an app user at all, then they'll be moved maybe onto telephone. or video. And if there's any concerns, then it's escalated in a face-to-face thing. So dependent on patient and clinical factors as well as to what level of appointment patients need. So we had some things prior to this that helped us. We had a biologics database. Obviously, we know which patients are on the biologics medication, and we knew about obviously when their last consultation was, so we could set up the clinics. And the EPROMs has been really important to allow us to do that virtual review, but moreover has helped us even when we can't do a virtual review and we do have to call them on the telephone or a video call. It gives a lot of confidence if you have recurrent data from the patient over the last few months to make you confident that, okay, even if there may be some concerns, that actually you're happy with how things are. You get a much better idea about how they've been doing. And this goes for even if you see them face to face, you get a snapshot of how things are. So how have we moved from it? Initially, the old service pathway in the first year had 5 face-to-face appointments in the first year, and every 3 years after that, 6 face-to-face. Now in the first year, it's 2 face-to-face, and every 3-year cycles, provided it's not escalated upwards, it'll be 1 face-to-face. And we've moved a lot more over towards using our AHP team to lead that. So we've aimed to get a more sort of, this was initially in response obviously to COVID, but making a sustainable pathway in the longer term, improving remote working as well, so that we can make maximum use of the actual clinic rooms, because we have a great pressure on the actual physical space. So this, you know, if we can do telephone and video calls and virtual reviews, we can free up those clinic rooms. And ensuring a patient focused service, and also applying some of the principles of PIFU. So just looking at outcomes, before obviously it's 100% face-to-face, now it's about 9% face-to-face, 10% video, 61% of appointments are telephone, and about 20% are virtual reviews. So we use that sort of data to then have a look at how much that improves in efficiency. Now, a virtual review takes about, this is where we use the app scores and the checking the blood tests and don't actually call the patient, takes about 15 minutes in total, including the administration time of filling out the pro forma and getting that out to the patient. So a face-to-face review takes about 40 minutes. That's about 30 minutes face-to-face and a 10-minute sort of admin time. So we kind of multiplied that up and worked out that it saved about 140 hours of clinical nurse specialist time over the course of a year. In terms of looking at cost savings, now I would say there's a slight caveat to that. We've been on a block contract over COVID, so we had to use the previous NHS tariffs to kind of work out, I guess, slightly theoretical cost savings, but this is what the cost savings were. So face-to-face is £120 for a tariff, telephone review tariff is about £60. Before COVID, there wasn't such a thing as a virtual review, so we've taken a worst case scenario from I guess a commissioner's point of view, and said a virtual review costs the same as a telephone review. And if we worked out the various cost differentials of doing it all face-to-face to what we're doing now, it's about a £72,000 saving per year. In terms of patient satisfaction, do they like this? So patients have the option of filling out a SurveyMonkey thing at the end of their virtual review. So when they get their clinic template letter, it comes through, it says, please let us know how you do. With all these things, you never get as many people as you really want to fill these things in, but this is who has filled it in. About 90% are very satisfied or satisfied, and they found it generally convenient, reliable and effective. There was one person here who was particularly disgruntled with his experience, so that's didn't feel it to be such great quality. But overall, people were pretty happy with how things were and would be happy to have another review like that. So what are the ingredients for success? And Gwai has alluded to a number of these before. We had an engaged team. We've got a good database structure, so we can keep on top of our biologics patients. The remote monitoring platform has been really important in making patients feel really connected to the service, and also for us to know how they're doing between appointments. It's important to have clear communication, but both between the staff, but also between patients and the staff, who and when to contact. Safety netting procedures. We tell our patients we don't check their scores live. They must contact us if they have an urgent question. And also important to really stress to patients that we're using their data. It's important to us and it helps us understand how they're doing. So scaling up wise and what we're going to do next is really important, trying to embed this more into our routine clinics. It is used on an ad hoc basis in our routine clinics already, but we're trying to look to sort of formalise that a little bit more. I do a virtual clinic which is entirely online once a week with 11 patients, which I just work my way, see all via telephone or video. And the app certainly has helped me a great deal in being confident to make medication changes there. And we've also had a lot of support from our ICS and neighbouring hospitals who are also looking to use this, who are actually now using this in their service as well. So really it's using data to widen this bottleneck. It's a tool to facilitate change. It means that you can really help maximise your remote consultation decision making and facilitates a bit of triage, which certainly with PIFU and the remote therapy clinic that we're using important, and helping patients to engage in the management of their service. So thank you to our wonderful team who have put an enormous amount of work into this, and I will stop there.
Excellent. Thanks, Phil. That was great. Do we have any questions from the audience? I can't see anything in the chat. Any questions out there? So there's Chris Robson, in the midterm, should more of your two-way communication and understanding of flares and potentially engagement with patients be digital via the app rather than via your helplines, or both, as suits patients?
Yeah, so Chris, that's a good question. And I think a lot of this comes down to looking at your local resources and how your clinical pathways run. I think what's important, I guess, when using something like this is that we and Gwai the same started off using this quite organically. So, you know, we didn't try and go in with a big bang change to everything and the app is being rolled out for everyone. It was, we sort of tried it, we used it in small numbers of patients to get going, confidence to sort of develop among clinicians, and the sort of then you can see where the use really fits in with your service, because it will be different for different hospitals. I think in terms of two-way messaging, I think it's another avenue in for people, and I think it's important to sort of work with your team and look at how your workload and your workflows actually fit, and where you think you might be able to potentially save time and be more efficient, because sometimes if you don't have particularly good pathways, you end up with duplication and people contact you on an advice line, telephone, sending you a message here, sending you an email there, sending you an email through to your secretary. So I think pathways are really important in fitting there. I think flagging up flares, it's really useful when I see patients in clinic when they've recorded flares, because actually sometimes patients have flares and they want to record their flares, but actually they don't necessarily want your input. They just want to record it there. And so that's useful clinical information, because when you see them 6 months later in clinic, they may forget to tell you about the 4 or 5 flares that they've had. But if it's recorded down there, you can say, do you know what, actually between your flares, you're fine, but you are having a flare every 6 weeks or so. Maybe we should tweak your medications a little bit. So I think it's working out at your own sort of clinical level whether this sort of really will be useful for you. I think for some people it'll be really helpful. For other teams, they might just say, do you know what, we've got a really robust telephone appointment things. But what I would say is, even if you're just working down your existing care pathways, this gives you in seconds a summary of how this patient's been. You don't need to sit down and spend 15 minutes going through all of their clinical history. You can go, do you know what? I know how this person is. So, yeah.
Great, thanks, Phil. We've got some questions. We have Katie, and then Brian, and then we have some questions in the chat. So, or Kate, sorry, Kate Pound.
It's okay, that's fine. So I was wondering, in part of your, you know, when you put your patients into different categories for monitoring, so like red, you just got the traffic light system. Have you applied any scores against deprivation to kind of take that into account? So it's not all just about the physical, it's more about the social as well.
Kate, excellent point. And the answer, unfortunately, is no. These are the sort of things that, you know, I'd love to do as part of, you know, wider sort of research, and to really build that in, because deprivation affects people in lots of different ways. it can affect them in the way of maybe not having the technology or the data contracts to be able to use that. It can work the flip side, and I have had patients who said, you know, I can't attend your appointments because I'll get the sack from my job because I keep taking this time off. So it works both ways, and it's a very heterogeneous thing. Then you've got people who English isn't their first language and they might find it difficult to work with these things. So a very important and diverse question to that.
Great, thank you. Brian, is your hand
Hi,
up?
Philip. Yeah, excellent presentation. Just wondering again, how often do your patients actually use it? Or is it on an ongoing basis? Is it just before their clinic appointment? Or what have you found? Do you kind of mandate them to use it or ask them to use it at certain intervals, or is it more organic?
So the app itself has a reminder for the outcome scores that varies dependent on the outcome score. I ask patients to set that up so it pings up as a reminder for them. When we last looked at data, which was a couple of years ago, and we're looking at it again, but I don't have the data right now. But if you ask people to fill in an outcome score every week, they fill it out on average every 2.5 weeks for the Rapid 3 questionnaire. So that's about on average how often they're doing that. We don't mandate patients to do that because it's I think that's practically quite difficult to do, and we kind of want to bring people along with us as much as we can rather than mandate them. And I think the other thing is, yes, asking them to fill it in before their clinics. It's again, we haven't yet worked that out in terms of our clinical pathways. It comes down to really sort of rather mundane things, such as like, can we change the standard text on our clinic invite template letters to say, please fill in your app score before your appointment, which is harder than you might imagine, or maybe you know. But yeah, so at the moment we use it sort of very much with patients sort of consent, if you like, going along with us rather than mandating it. And about 2.5 weeks is roughly on average how long they'll fill it in. But there's a broad range of engagement.
Right. Thanks, Phil. We have a question from Lawson Simpson on the comments saying, does your trust use System 1? And if you did your team explore adding this feature to System 1?
So we use Careflow, which they've got lots of different names, so I don't think it is System 1. It's in our one the Careflow only came in at our hospital about 3 months ago. But they have a third-party button which that you can automatically open up the window. We haven't yet, because we're in the queue of getting integrated into it. So that's possible. At a sort of data integrity point of view, you can just ask the company will send through a CSV or whatever data format you want it to send it through to a data warehouse on a regular basis if you want for medical legal purposes to just have the data rather than it necessarily being sort of shown in any way. I don't know about System 1 and the integration into the actual various windows that they have there.
Great, thank you. And we have a question from Tala.
Yeah. Hi, Philip. Thank you, guys. It's really good presentation. Just want to ask you one thing, so I was looking at your new service pathway. You mentioned that, you've moved a lot of things to virtual telephone video. Did you consider automating some of those pathways? So instead of taking £60 tariff, something you can automate, so patient would actually fill in. So did you consider, or have thought about this?
So yeah, so I mean, there's aspirations for automating, and I guess maybe going back to Gwai's picture of a Tesla, the technology is definitely there. I think a lot of this comes back to patient engagement and making sure that they actually are using it regularly, and we're quite, I think, as a profession, we're quite early on in that sort of pathway of getting patients to engage with medical apps in a way that actually influences their care. I think patients are generally, by and large, ready for that sort of thing, but there's so many safety nets that you have to build into it, and then integrating that into care pathways, and also having buy-in from colleagues that an automated care pathway is the safe way to go. I think eventually we'll get more and more to those sort of things, but it's certainly in our trust we're not there yet.
Great, thanks, Phil. I see our time is up. I feel these conversations could go on for quite a bit longer. But for now, I think, yeah, we're at 1:45. So a huge thank you to Guy and Phil for some fantastic talks and absolutely lots to think about. Okay, so thanks everyone, and goodbye.
Thank you. Thank you, guys.
Thanks.
Thank you.
Thank you very much to all of you.
You're still recording?